My topic today is about anaphylaxis, probably just a quick overview of the recent advances over the last probably 10, 15 years in the understanding of anaphylaxis. Okay, so probably we will shed some light on the definition and grading of anaphylaxis, prevalence, risk factors, talking about a little bit about biphasic reactions, genetics of anaphylaxis, some pathophysiologic mechanism involved in anaphylaxis, then applying probably precision medicine description on phenotypes, endotypes, and biomarkers of anaphylaxis, talking a little bit about elicitors and cofactors, and probably ending with treatment recommendations for a case of anaphylaxis. Now, epidemiology of anaphylaxis is actually is showing that there is the prevalence is increasing and the hospitalization is actually increasing. I mean, if you look at data for elderly people, where the numbers have been doubled over the period between 2000, it's just flipping automatically, which has increased between 2000 and 2010. Admission rate as well, they have increased threefold over the last 20 years. Lifetime prevalence, I have a problem. Prevalence in general is thought to be around 2% or less than 2%. The alarming thing here is the recurrence rate among patients who experienced anaphylaxis, where actually it can reach up to 50% of cases if they were followed up to a period of 25 years. Now, biphasic anaphylaxis, which we are going to define later, is estimated to be around 4.7. Sorry for this, it keeps flipping by itself. Prevalence actually post-traumatic. Hey. Okay. Yeah. Okay. Talking about post-traumatic stress disorders, which are actually appreciated in 41% of patients who experience anaphylaxis. Now, in mastocytosis as a risk factor for mastocytosis, I mean, different percentage of risks have been associated with anaphylaxis, ranging from 12 to 50%. Now, talking a little bit about mortality, I think we will live with this, keeping flipping by itself. Mortality of anaphylaxis has declined in some instances, or at best it did not change. With just the exception of Australia and USA, where they have showed increase in mortality of anaphylaxis related to drug allergy. Now, trying to define what is anaphylaxis, I think we'll start with the name. I think the current recommendation is to avoid using the word anaphylactic shock, anaphylactoid shocks, and stick to the simple word of anaphylaxis. Now, we consider anaphylaxis as the severe and end form of an allergic reaction, ranging from, acute urticaria, angioedema, and anaphylaxis. It took several probably rounds of, guidelines or protocols to come up with a proper definition of anaphylaxis. All those definitions you see, they emphasize one thing, which is that it is a rapid, generalized, and life-threatening reaction, which we need to examine carefully, because I think data from case series and registries shows that there is no increased mortality or morbidity associated with anaphylaxis. Majority of those patients who presented with anaphylaxis actually came late to ER, and they did not even receive appropriate epinephrine treatment. The word generalized is questionable, as we have some cases where there is no multi-organ involvement. We could have isolated respiratory, isolated cardiovascular, and even isolated cutaneous symptoms. The word rapid, even questionable, as some cases of alpha-gal syndrome, they can present after 10 hours actually of ingestion of meat. So putting those problems together, can we consider anaphylaxis as a rare disease, and probably recognizing it every single year on the 28th of February along the list of rare diseases? Now, criteria for diagnosis, multiple criteria have been used to define anaphylaxis, but I think, you know, the WOW in 2020 put sort of this criteria for diagnosis, and it should fulfill either acute onset of illness where there are mucosal or cutaneous involvement, okay, and it should have at least one of the other ones, either respiratory, cardiovascular, or severe GI symptoms, or a presentation with either pulmonary or cardiovascular in absence of cutaneous manifestations. That's after exposure to the known allergen for the patient. Now, patients with anaphylaxis can present with multiple manifestations. Skin manifestations are predominant, followed by bronchopulmonary, cardiovascular, and neurological, and so on. Now, one of the things that have been and talked about actually is the severity grading of allergic reactions. And this has been compiled in terms of an attempt to standardize research outcomes and probably a better way of communication between doctors and patients. One problem is that this needs to be validated for clinical use, and it should not be sort of a rigid guideline to emphasize when to give epinephrine and not to give epinephrine. We have another three terminologies we need to be aware of. One is the persistence anaphylaxis. And in this, the criteria is that patients should fulfill the criteria of diagnosis, and that the anaphylaxis symptoms has been around for at least 4 hours. Refractory anaphylaxis, there are two criteria again. You know, the presence of anaphylaxis following appropriate treatment, and the treatment has to be giving more than 3 doses of epinephrine. Biphasic anaphylaxis, they have put 4 criteria for that. Is that the patient has to fulfill the criteria of diagnosis. Initial symptoms will fade completely or resolve completely before the onset of the new symptoms. During this period, the patient should not be exposed to the allergen that caused the initial symptoms. And the recurrent symptoms should be within the time frame of between 1 to 48 hours before resolution. Now, when do we need to think about biphasic? I mean, what are the sort of risk factors that we need to look at and probably label the patient as having high risk for biphasic anaphylaxis? And it seems that through the recommendations that probably 2 variables are very, very much important. If the patient received more than 1 injection of epinephrine, that puts him at a high risk of developing biphasic. And therefore, it has been recommended that the observation period following anaphylaxis to be extended in those patients. There are additional risk factors like the wild pulse pressure, if the trigger of the anaphylaxis was not known, cutaneous signs and symptoms, and the drug trigger in children has been as other additional risk factors. Now, should we administer antihistamines and glucocorticoids to prevent the biphasic anaphylaxis? And I think the recommendation is not. Anyway, the evidence for that is still very low, but still so many people are doing this. And we administer antihistamines and glucocorticoids in every single patient presenting with anaphylaxis. Now, talking about triggers, and when we talk about elicitors and cofactors, elicitors are probably the cause of anaphylaxis. And the three categories most known are the food, insects, and drugs. And as you see from the table, these factors or elicitors actually, they differ from one region to another, and even they differ by age. So what is important or very high in one area might be negligible in some other areas. Unfortunately, we don't have really good studies in this region defining the elicitors and cofactors. We have sporadic, probably single center description of the elicitors. Now, the cofactors could be either endogenous or exogenous. And the next question is, which one much more important? Is it elicitors or cofactors in causing a severe reaction? And to answer this, one of the group in Spain looked at this, and probably they had 55 patients with, they had 55 patients with 150 sort of reactions. And the conclusion they came out with this is that neither the elicitor nor the cofactor were very important in deciding the severity of the anaphylactic shock. And they thought there might be some other individual sort of characteristics which lead to severe reactions. Taking this further, an elegant study by Rose Garcia, they were actually following up patients in a clinical trial. 57 patients were having a double-blind, placebo-controlled food challenge with peanuts. And they managed to sort of record the hemodynamic changes in those patients. And what they've noticed is that regardless of the severity of the reaction, there will be decreased venous return, decreased stroke volume, and increased heart rate. I think we knew this from what we've seen in patients, but probably this is a big study which looks at all patients going through anaphylaxis. The good thing here is that restoring blood volume actually improved the symptoms, and actually it sort of abolished the gastrointestinal manifestations of the disease. So the conclusion here is that severe anaphylaxis related to probably poor compensatory mechanisms, cardiovascular, I mean, that contribute probably to the severity of the symptoms. So anaphylaxis probably is the end result of combining cofactors, genetics, and pathophysiologic mechanisms leading to activation of mast cells, basophils, neutrophils, macrophages, release of mediators, and through those mediators, you will have your clinical manifestations. Now, when it comes to pathophysiology, people have probably looked at 4 or 5 different pathological mechanisms involved in pathogenesis of anaphylaxis. Classically, we've been talking about anaphylaxis as an IgE mediated, and through those pathophysiologic mechanisms, I think the terminology has to be extended. So it's no longer just an IgE mediated. Many other pathophysiologic mechanisms can lead to anaphylaxis. Again, this is the same description of the events leading to anaphylaxis. Now, this is probably a working sort of diagnosis of anaphylaxis and how do we need to manage our patients. So any suspected patients presenting with the clinical features and signs and symptoms as per guidelines, okay, should have a tryptase be measured. and we'll talk about the tryptase in a minute. If that's normal, then probably we need to investigate later 4 to 6 weeks. And I think this is very important, is the time frame when to investigate post-anaphylaxis, and mostly they will consider 4 to 6 weeks as an appropriate time to do that, not before. So skin testing, specific IgEs will help to probably define the elicitor in some patients. If the tryptase was elevated, then you need to measure a baseline tryptase, which is again 4 to 6 weeks later, to have a better understanding of the elevated tryptase level. If it remains elevated, then I think genetic sort of mutation in the c-KIT will help, along with the familial alpha trypsinemia, which is becoming a hot topic actually in understanding the elevated tryptase level in some patients. So this is a working sort of idea on how to approach patients with anaphylaxis. Okay. Now, since we mentioned serum tryptase, unfortunately, not all hospitals we knew about, they have serum tryptase. Still many ER, they don't have serum tryptase, and this makes the diagnosis a little bit difficult sometimes. Anyway, so tryptase is released within minutes from mast cells, basophils, and usually resolves within 24 to 48 hours. Now, the commercial assays, and I think there is only one commercial supplier of serum tryptase test, which actually look at the total released tryptase, which is basically the baseline, and this reflects the burden of mast cell plus the mature, which is released upon activation. So this is the total. And a cutoff point of more than 11.4 has been used as an indicator of mast cell or basophil activation. Now, tryptase is known that there are 4 genes controlling tryptase activity or production: alpha, beta, gamma, and delta. The most important are the beta and alpha. There are 27% of patients, mostly white patients, who have absent alpha genes. And this is not really reflected in the total serum tryptase level or even activity. We have another category of patients where they have low baseline tryptase, and during anaphylaxis, the level goes up, but not to the level we mentioned, which is more than 11.4. So another set of cutoff point has been designed, which looks at having 1.2 times the baseline plus 2 nanogram is considered as an increase or elevated serum tryptase. Specificity of tryptase test is high. However, the sensitivity is low, probably mostly because patients are tested late during the course of anaphylaxis. Serum tryptase, again, they shows variability among the elicitors, where we see with the drug-induced allergies, the values tend to be higher than with food drug-induced or food-induced anaphylaxis. Familial tryptosemia, where they have an extra copy of alpha gene, and they tend to have a higher level of sort of serum tryptase than normal, and we need to be aware of that. I'm not aware of any study in this region, actually, which looked at familial tryptosemia. Now, this is another sort of easy, maybe to use indicator of whether we are dealing with a refractory or just a responsive anaphylaxis. This is, I think, a Korean group which looked at the ratio between neutrophil to lymphocytes during anaphylaxis. And they used a cutoff point of the ratio of less than 0.68. And according to this group, this has been able to define patients actually who will go into refractory anaphylaxis compared to other patients. Now, so probably just to summarize, I'm not going to take you in details, but over the last few years, I think there are few advances happened in the genetics, where having a combined mast cell gene along with hereditary or familial alpha-tryptopemia, this will increase the severity of anaphylaxis. There is one case of KRAS mutation, which has been considered as a novel mechanism leading to severe anaphylaxis. New biomarkers have been identified, but they have not reached clinical use yet. We have a better definition of the severity, grading, and the biphasic sort of anaphylaxis. Treatment-wise, nothing has changed in the previous guidelines, except for the highlighting the importance of fluid or early fluid application during the process of management. And then the long-term use or after anaphylaxis, the use of anti-IgE alone or in combination with oral immunotherapy as a way to prevent repeated food-induced anaphylaxis. I think I need to stop here, okay? And thank you very much.